Hi, Dr. Rauthan. I don't know.
Hey, hi. Hi.
Do you remember?
Yes, yes, yes. Yeah.
Okay. Yeah. So it's been like almost 8, 9 months now. So,
I
Dr.
know.
Rauthan, without wasting your time, because I know that how many patients are always coming in to, and they are lining up, be near your cabin. So, tell us, like, what have you seen during your experience that how the number of patients have increased over the years, and what is the trend in terms of cancer, and what cancer is impacting us the most?
Yeah. So I think over years that this is what we have seen in practice. The number of cancer patients has gone up hugely. It's definitely gone up. And we keep talking about this, debating about this, what could be the reason why cancer is going up. And we possibly think it is all because of multifactorial. It is multifactorial. There could be a lot of environmental factors. There could be a lot of dietary factors. There's a lot of factors acting on a genetic basis and on the background of our genetic basis. And it's an interplay of so many things happening. And but 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 whatever said and done, we are clearly seeing numbers are going up and up. And if I could say which one specifically, we see a lot of increase in breast cancer. That's something we are seeing a lot more. And even in breast cancer, we are seeing much more cancers in younger women with breast cancer. And this has been a change over the last few years. We have seen more and more patients we are picking up at a younger age group. We are seeing higher incidences of colon cancer. Again, colon cancer we used to say was a more of a disease of the West, but you're seeing also a lot of colon cancers which are picking up, and again, younger age group colon cancers have been picked up.
So,
We
if I could
Yes.
just ask you the numbers, tell us how many new patients are coming in every day. How many patients are you really seeing every day? So that the viewers will have idea that how grave is the situation. Because I have seen those queues, so I can tell you that how is the situation. But please tell us the number. We want to hear from you. And of course, tell us about the age group, how the age group has changed of the patients that you are seeing.
So if I talk about breast cancer, which is the commonest cancer we see daily in the OPD, if we see about 30, 40 patients, we are ending up seeing at least one or two patients new with breast cancer. Now, I would think this number will be much bigger in a regional cancer center, in regional cancer centers where you deal with huge volumes coming from all over the city, all over the state, draining areas. The volumes are going to be much, much bigger. So my thought is, uh, we are only the tip of the iceberg. We are sitting in exclusive centers where we are seeing selected patients, but even we feel our volumes are more. I can tell you how regional cancer centers will be dealing with volumes. Also, there was a time in breast cancer 10 years ago or 15 years ago when we used to talk about older women having breast cancer. We used to see our patients used to be 60 plus, 65 plus, 70 plus. We know age itself is a factor for breast cancer. And those were the age groups we used to see. Nowadays, if you ask me in the last 5 years, last 10 years, most of my patients will be in that age group between 30 to 50, 30 to 40, 40 to 50. And this is the age group where you really are not hoping to see breast cancer. But that's the unfortunate way cancer incidences have gone up. And the prevalence is much more. Younger women, unfortunately, have higher breast cancer. Uh, what I would say is more aggressive types of breast cancers. Unfortunately, that's the type of breast cancer they have. So
Hmm.
that's definitely the changes we have seen.
And then when it comes to treatment, uh, it drains out the family. It is not just for the patient. Of course, we say that the patient is in pain all the time, of course, but it is very difficult for the caregiver as well. So, with your experience, tell us that what do you tell them, and what do you suggest them, what is the right way to deal with it, when to decide what to do, because the entire process of treatment is so expensive.
Absolutely. I feel the way our cancer care has kind of moved forward. What is happening is, we are picking up most of our patients in advanced stage. And when you start picking up your patients in advanced stage, you can't cure them. And the hope is by treatment, by suppressing the disease, you're trying to increase their lifespan and trying to maintain a quality of life. But this this part of treatment which happens in stage 4 will come with a huge expense because it is an ongoing treatment. And even when we talk of all new therapies, we want to advocate and we want to integrate so that we get better lifespan. We spend a huge amount, but we know we are not curing patients, we are increasing lifespan. So we kind of always lay emphasis on, if possible, detect the cancer early. If we catch it early, the treatment is limited and the cure is good. So if I catch a breast cancer in stage 1 and stage 2, the cure rates are higher than 90%. But if the same breast cancer I catch in stage 4, there is not a cure, though the lifespan will increase many years, but they will be on ongoing treatment throughout. So the whole message is we need to catch our patients early. Yes, how to catch is a tough thing because it can happen that patients won't come out of it because of their symptoms. So they need to be aware. If they have a symptom, they need to go for a checkup. That scare of cancer should not be there. That scare to go to the oncologist to get it checked should not be there.
So what are the steps, like, do we need to make it like a routine that we have to get the checkups done every year? And what checkups can a person, get done for male, female, of course, for both, that they are in peace of mind and they will not live in the fear, to reach to the doctor in stage 4 or stage 3?
So that again is the difficulty with most cancers is there is no one screening tool which covers all cancers. Unfortunately, there are only few cancers which can be screened and caught early where you can make an intervention and prevent it from happening. So we say for females, we say for breast cancer, start mammograms when they cross a certain age group. If they're normal age group, we say above 50, they can start doing mammograms. If they have a family history of breast cancer, they'll have to do it even earlier. Or if they have a genetic risk, they have to do it even earlier. And they keep doing regular mammograms that can pick up breast cancer. For cervical cancer, we say by doing testing for the pap smear and looking for the HPV, we can pick up early by doing these kind of tests. For colon cancer, again, there are some screening guidelines, but in India, we hardly follow colon screening cancer guidelines. In the West, there are guidelines that at 50, you have to do a stool test and a check test and a colonoscopy, and every 5 years you need to repeat it, or every 10 years, depending on what test you do. These are ways by which you can pick up some cancers early. But in reality, screening in India is very minimal, though we are trying to expand the information. There are a lot of hesitations, and of course, our population is very big. I would recommend, instead of that, one way of it is, if anyone has any symptom, go get it checked. So if there's any new lump happening, any bleeding happening, any weight loss happening, any cough which is not going down, any pain which is not going down, in those kind of things, it is better to go check it out with the background that also rule out cancers. That way, at least you will look for it. That's what we advocate to people, saying that if you have any symptom, it's worth checking it out once and ruling it out. But unfortunately, I don't think we can screen for all cancers and say, if anyone walks in and says, tell me I don't have any cancer, it is impossible. That's the way the
So
disease
many
is.
steps that you have to go through to figure out
Yeah.
that you're safe. So overall, since we last met, any new changes, any new improvement? Like, at that time we were talking about immunotherapy, but tell us about the success rate so that people are aware that what they are choosing, and if there are new improvements, new medicines, any new development in the field.
So the science of the disease is developing a lot, in which there's a lot of understanding of the biology of the disease. So a lot of thought is going into molecular genomic analysis of the cancer to understand why the cancer is propagating, why it is spreading, why it is metastasizing. But unfortunately, we still don't have targets all over to block those and say the cancer can be cured in advanced stage. Now, so a lot of two major things going on at present in the oncology field. One, as you mentioned, immunotherapy is really going up and up and up the ladder. We started a few years ago with immunotherapy in selected cancers, and now almost, if you see the list of cancers where immunotherapy is now FDA approved, the list is huge. It got approved. It started from kidney cancer and melanoma and lung, and now it has moved into almost every cancer: esophageal cancer, gastric cancer, selected colon cancers. We're talking of Hodgkin's lymphoma. We're talking of head and neck cancers. But we are understanding also that immunotherapy works in selected patients, but where it works, it can work wonderfully well. And we have now patients who responded very well. But we also are understanding immuno doesn't work in many patients, and then it becomes very disappointing because it's a huge expense of treatment.
What is
So,
the success rate in that? What is the success rate of immunotherapy? If
so if you, it depends entirely on the cancers you're treating. In kidney cancer is one place where immunotherapy is showing very good success. So we have a big number of kidney cancer patients with stage 4 disease who are living for many years now after being treated with immunotherapy, even after stopping therapy. And we have a big number of patients there. But if you ask me, is it showing the same results everywhere? No. In lung cancer, we have selected patients doing very well, but we have other patients who don't respond very well to immunotherapy. Similarly, in other cancers, even in colon cancer, the results are very mixed. You'll have a small population who is doing very well, and you have another population who is not doing well. So, so now a lot of research is going into looking for biomarkers to say which patient will respond to immunotherapy and which will not respond to immunotherapy. But unfortunately, we still have not reached that stage. So that's the reason why immuno is the most talked about treatment for cancer care. It has moved up the ladder from stage 4 to stage 3 in lung to stage 2 in lung. You won't believe it. Even in early stage cancers now, immunotherapy is got approved. But yes, there are patients who are benefiting hugely from it, and we have seen that success in that group of patients. So we keep hoping that immuno will be a good responder, but then some don't respond well. The good thing about immuno is it doesn't have the side effects of chemo. So for patients where it works, we can give it even to elderly patients with good responses. But again, as I told you, there's no biomarker.
but
The other advance is the sorry.
Sorry. So I was saying that if we have any data, can we talk about that? What is the success rate that we have in
Yes.
terms of kidney cancer
correct.
or colon cancer?
So kidney cancer, we actually published our data in our center because we kind of picked up immunotherapy when it came in 2016. I can tell you an incident of one of our patients because he propagates immuno also. He talks a lot about it everywhere, and he was our first patient, and it was in 2016 who with kidney cancer, which had spread everywhere in his body. He had received treatment with sunitinib, the standard of care, and had progressed. And at that time, there was no treatment option. He was so sick, he ended up in the ICU, going to the level of almost coming to palliative care. And that was 2016, and immuno had not been launched in India. His family, his wife actually told us clearly that give it the best try you have, whatever you have. We told him we would think palliative comfort care because we have used everything we had in India at that time. And she actually told us, please get the best of medicines, or I will take him, but I can't fly him because he's very sick. So we got the immunotherapy drug, imported it, and when 3 doses, we saw it in 2016, the whole cancer melted away. Now, he went on to take immunotherapy after it got launched in India. He continued it, and we gave him immunotherapy for 1 year. And we kept doing PET scans, and to our surprise, every PET scan after that came negative. There was no cancer. 2017, we stopped his treatment. Even now, this January, he came, did a PET scan. He comes every January. He says, punctually, I will do a PET scan because I know what my disease was and I would like to see I'm doing well. This January, we did a PET scan, 2023. He is still cancer free. And he was a patient who ended up with palliative care. So he was one of the first patients in India to get immunotherapy for kidney cancer. So I keep saying, we have patients of this kind. In kidney cancer, we have a big number of patients. So we have treated about, if I tell the number of kidney cancer, we have actually reached almost about 100 patients of kidney cancer whom we have given immunotherapy. And we have seen good success in about 60 to 70% of patients. It's a remarkably good data. But if you ask me, there are, unfortunately, when you talk of all this, one needs to understand immunotherapy comes at a cost. It's a huge expense. The international guidelines give immunotherapy indefinitely. They say you have to keep continuing it. And if you talk to experts in the West, they say you keep continuing it. But in India, that's not possible. So what we are doing for many patients is, if our scans are negative, we are trying to stop the immunotherapy at 6 months, 1 year. Most of my patients at 1 year, we try and say, if the scan is good, we will stop and we will watch. Yes, if the cancer comes back, we will restart. If it doesn't come back, we are very lucky. And now we have a cluster of, at least I would say, around 7 patients of renal cell cancer who we are watching for many years after stopping immunotherapy, and the cancer has not come back, though they were stage 4. So we have very good success in kidney cancer, and I keep believing kidney is one place where immuno is a dominant drug. Now, unfortunately, the success is not the same in lung cancer. If you ask me in lung, the success is much lesser. There are patients, yes.
There are too many unfortunate things in cancer, actually. That is so true. And yeah, so one thing is, of course, it's there that for kidney cancer, as you're saying, it's 60-70% success rate is great. But in other cancers, what would you suggest, and how do you, because of course every family with their strength, they try to provide the best to their patients. But then how do you decide and suggest to the patients that what is good for you and what is not good for you, and how difficult is it for you as a doctor, because on daily basis, I have been to the wards, to the where the cancer patients are kept, and I would see a death, one or two, almost daily. So I know how painful it can be. So how do you deal with this on a daily basis, and how to guide people?
So these are very, what you have brought up is a very difficult and sensitive issue. Uh, so so there's a lot of conflict there. And this conflict has become much more after immunotherapy has come into the picture. So earlier, in stage 4, we had chemotherapy, and we knew chemo could work only limited. We used to give 1-line and 2-line chemos. After that, when chemo progressed, we used to tell our patient that we have tried our best, and most patients could not tolerate chemo after some time because chemo has its own toxicities. In stage 4, we used to leave them on palliative comfort care, saying that we have tried our best, let's leave it at comfort and keep him pain-free. Now, after immuno has come in, the problem has become it's become a very dilemmatic situation because there are few patients who respond dramatically, and there are many patients who don't respond. So it becomes very dilemmatic for us to tell patients also, no, there is no choice, there's no hope. Or what if this patient turns out to be one of the lucky ones who respond? So there are, suppose I say head and neck cancer, even in head and neck cancers, there are 20% patients who respond to immuno, 80% don't respond. But for that 20%, it's an exorbitant cost. So it's become very dilemmatic. What we are doing as of now is we sit with patients, we sit with families and try to explain to them, that the hope is this much, but the reality is that much. And we have to, sometimes it's like, you're gambling between choices, hoping that you will fit into that 20%. But yes, we keep telling patients, we are relying on hope and trying. But if in a few cycles you don't get response, there's no point trying to push it more and more, because sometimes you're just going to have more and more cost. But in 2-3 months, if you respond, you have hopes which will open up more.
It's something that when do you say no? Because even the patient is suffering throughout the process.
Right.
So
Right.
when do you think is possible for a family to accept, or when can someone accept that, okay, this is something that, I cannot try more?
Yes,
Or is
I
it just
think that
personal choice? What is it?
I know. I think that is so. That is a very kind of a candid discussion required with the patient and the family. So, unfortunately, ideally it should be the patient making all those decisions. But most of our patients are not in that condition to take decisions sometimes. So, in our situation, it ends up with sitting with the family and taking those decisions. But every time when we try a novel therapy, we shouldn't go on trying and trying. We should, if you try it, we say try it for a short time, see whether this patient showed some response, didn't show some response. If it showed positive response, then we try further. And if it shows negative response, then we should not try further. But the other side is, whenever we try even with that 15 to 20% response, we should not push it for everyone saying, do this, you will be in that 15-20%. We are seeing lots of failures. We are seeing a lot of patients who don't show that response. So we try to sit with families, trying to explain our realistic expectations are these. This is what can happen. And if we are lucky, this is what may happen. And you sit with a balanced decision. Lots of discussions go with pros and cons, pros, cons. And of course, with that, the finances associated with that. So I kind of think this is the most difficult decision making for us also, and for the patients and the families also, because you want to hope for that. But so the reason why I end up hoping is, when I've seen my kidney cancer patients, like even I tell you in the example of my first kidney cancer patient, I was not hoping for it. I actually had given up. But there, the family insisted. The wife said, let's try if it has come. Why are you not open to it? And we were shocked to see the response. We had never imagined he would respond. And when you see him now, 6 years down the line, when I see him, he's leading a normal life. So that hope is there. But yes, we have to keep our realistic view also, that that hope will only happen to a small number of patients. It doesn't happen to everyone.
Yeah.
It's a very difficult decision. I understand, I keep going through this dilemma every day.
And you think something can be done in India? Because now it is like, I think if I'm right, then it is the second leading cause of death in India. And government can do something special, because it's not easy for a general family of India to, if they have someone suffering with this disease, it's very difficult to go ahead with the treatment, complete treatment. So
Correct, correct.
the idea,
I,
what do you think, what can be done in a country like India with 140 crore people?
yeah, no, our problem is the population and the extent, and the diversity. There is so much diversity, and every place has a different approach. So, so, so the government is doing things, but also what we are seeing is there are cancer-specific I would say programs being developed, and there are some cancer national grid is one thing where a lot of cancer centers have collaborated with each other. You know what? All the emphasis is becoming more on early detection, early prevention, early treatment, rather than spending everything in late where everything is not curable. There's a lot of emphasis has to move forward. And that is something that can only happen with more and more information spread, that if you catch it early, there is a lot of money you're going to save. You're going to save lives, but you're going to save a huge amount of funding also, because you're not going to put the money into late stages. Secondly, I think a lot of, it's not easy for any government agency to say, let's make immunotherapy free of cost for everyone. It is just not possible. So that is not an Indian answer, because there is no way Indian patients, you will not have that much funds because of
Why
the
are
way
they
cancer.
so expensive, doctor? Why the costs are so high? What's the reason behind it? It's
So it's, yeah, I agree. This is how the science of development has happened. The research that went in, these are these are drugs with selected companies in the West, and they have spent huge amounts of research in it to get to it. But there is some news happening in India in immunotherapy care. Some new novel initiatives have been taken up. If you see, last year, Tata Medical Center did a immunotherapy trial in head and neck cancer using a very low dose immunotherapy. So what happens is, when they do a low dose trial and said it worked, you're reducing the cost hugely. So these are very novel initiatives for India, trying using new chemotherapy protocols or immunotherapy protocols which use low dose, which reduces the cost to individual patients. Secondly, once the patent moves off, there are a lot of companies looking at generic immunotherapies. That's something which will be looked at. And future, you never know, this is something that may open up new avenues also.
so so many cancer days, and you must have given so many interviews. But what do you think has changed? Of course, it is becoming more deadly. The disease is becoming more deadly. But what is the hope? What do you see? Is there any hopeful thing? Because we heard unfortunate so many times from you. So what's the hope ahead?
I know, no. I always say that's the problem, You can fight the disease to the best of ability, but sometimes it's the biology of the disease which takes the course. So my hope in future is, understanding the biology has to get better and better, so that we can use better measures to try and uh, tackle cancer. So I look at it as an example of lung cancer. Lung cancer at one stage used to be fatal for almost everyone. And now we have looked at how to pick up lung cancer into different biological subgroups by doing molecular testing, not called genomic testing. And there are many patients surviving many years with oral targeted therapies, with oral tablets. But those are specific subgroups. So when you start having understanding subgroups of cancer, there are targeted approaches which open up. So I keep hoping in future we will move to better understanding of this kind of the knowledge of cancer to utilize for treating it. That understanding has to come. I wish there's going to be more biomarkers to choose patients. For example, a biomarker for immunotherapy I want in future, so that we don't give blind immunotherapy to everyone. We give it to patients where there is a chance of a higher response. That hope will help patients better in the long run. And of course, I think only early detection and early treatment, early prevention is the way forward for a society like ours. Otherwise, cost is so difficult for our society. We know what stage 4 patients go through. So those are tough questions. The answers are not easy, but this is the way we have to move forward. But I always say, we have to keep trying. If we give up and say, no, it's a fatal disease, you can't do much, you're not going to get even a short time. We have to give patients an opportunity and a time for it, and we have to keep trying.
Even those moments come in families when they would go to any extent, they'll try any medicine. And there are so many, even in South near Bangalore, you have so many centers who give Ayurvedic medicines. I know that your typical answer would be that you haven't studied it, so you won't comment on it. But considering the pain of these patients and the families, I think it will be really lovely if you could guide us, because there are people who are like in first stage. If I can tell you that even before my brother, when just 2 days before the surgery, he said that let's see what we can do. Like, should I go for surgery or I should not go for surgery, or I just go for the Ayurvedic treatment that might work. So it happens with everyone who are facing it. So what would you want to tell them and what to decide? Because there's sometimes after losing them, we feel that okay, we might have just lived with Ayurvedic medicines for another 5 years, but in peace maybe.
I know these are very, very difficult I would say, questions to answer, because we keep hoping, that this Ayurvedic medicine is going to do very well. But my thought is always, when you see a big population where it has not worked, you kind of think, will it work? Then the whole thing comes down to the science of it. I keep thinking, if a proper study done with even these medicines will actually help open up newer avenues scientifically, then people will follow it. So that's why we keep thinking, yes, these are very interesting medicines. These are interesting concepts. They do work on the biology of disease in many ways, but they have to be properly scientifically studied. Doing a good scientific clinical study and trying to see where they may help may be a way forward. But till then, it becomes very difficult for us to say, do this and you will have a benefit. For us, we still say, that's the reason why we don't make decisions ourselves. That's the reason why all of us rely on cancer guidelines, because this is the only way we can answer scientifically that are we all doing the correct thing in the way which has been proven. And that's why all of us as medical oncologists all over the country, all over the world, usually will follow some cancer guideline. We will choose that guideline and then we'll stick to that guideline for that cancer. So that's the way I look at it. But yes, a future clinical study will definitely help answer better.
Right. Okay, it was pleasure discussing everything with you, Doctor. I'll share the story with Srinath and he will share it with you. I hope everything is great with you. Nice talking to you.
And nice talking to you too. Okay.
See you, sir.
Right. Okay, bye.